Okay, good day. So continuing with our hematology review, we are now going to discuss about the different leukocyte disorders. So I've classified these leukocyte disorders into four. This is for better understanding and correlation later with the different characteristics of or laboratory findings of these leukocyte disorders. So first we have the non-malignant. Okay, granulocytic disorders. For the non-malignant granulocytic disorders, they are actually classified into two. We have the quantitative abnormalities and the qualitative abnormalities. So the first four here, okay, are quantitative abnormalities, and we have the functional disorders, the nuclear abnormalities, and cytoplasmic abnormalities being qualitative in nature. Okay, so first, I'll just point out now the important things that we have to take note with regards to these non-malignant granulocytic disorders, because basically our focus or highlight for this discussion would be the malignant ones. Okay, so for the first, we have the physiologic pseudoneutrophilia. So from the name itself, when you say physiologic, that means it is normal in nature. And because it is normal, okay, because it is normal, we are not going to expect toxic changes when it comes to our white blood cells in this case. So when we say toxic changes, we are referring to toxic granulation, vacuolation, and the presence of Dolly bodies. So these changes are not found in physiologic pseudoneutrophilia. Okay, it's just that in this case, there is an increase in the number of your WBC. And when we say neutrophilia, that is an increase of greater than 7,500 per microliter. Okay, greater than 7,500 per microliter. That is our definition when we say neutrophilia. Okay, greater than 7,500 per microliter. So again, for the physiologic pseudoneutrophilia, it is a normal finding. Therefore, toxic changes are not found. Unlike in the case of pathologic neutrophilia, this is where we could find toxic changes already. Okay? So again, when we say toxic changes, we are to expect presence of granulations, vacuolations, okay, and the Dolly bodies. Next, we have the neutrophilic leukemioid reaction. Okay, so neutrophilic leukemioid reaction, later on, we are to differentiate this with chronic myelogenous leukemia, basically because they are showing similarities, especially on what we call the left shift. Okay, so this is characterized by a left shift. Okay, so when we say left shift, there is increased presence of immature WBC in the peripheral blood smear. So that would include bands, metamyelocytes, and myelocytes. Okay, so other than the left shift, one differentiating feature of leukemioid reaction from chronic myelogenous leukemia is that it will have an increased lap score. Okay. Next, let us proceed to the different functional disorders. So for the functional disorders, we have two to discuss here. First, we have chronic granulomatous disease, and we have Shediak-Higashi syndrome. Okay, so first, let's discuss about chronic granulomatous disease. Okay, so chronic granulomatous disease is basically this is a group of conditions wherein our white blood cells are able to ingest but cannot digest. Okay, they are able to ingest but they cannot digest the pathogen that they have engulfed. Okay, so basically this group of disorders is characterized by ineffective ineffective intracellular destruction of ingested organisms. And that is because of a defect, no? There is a defect in the respiratory burst. So the WBC cannot mount, no, the respiratory burst wherein there is production of reactive oxygen species, no? Kasi itong reactive oxygen species, this is unnecessary, no, in order for us to be able to kill, no, the ingested organism. So in the case of chronic granulomatous disease, no, if we are going to check, no, the WBC morphologically, it is actually morphologically normal. Okay? It is morphologically normal. However, yun nga, no, functionally, it is abnormal. Okay? So, if there is a particular enzyme, no, that we have to take note in the case of chronic granulomatous disease, that is the deficiency of the NADPH oxidase. Okay? So, a deficiency, no? A deficiency in, sorry, a deficiency in NADPH oxidase, no, because this NADPH oxidase is very important, no, in order for the phagocyte, no, the WBC, to be able to mount the respiratory bursts. So this is the enzyme, no, that is essentially deficient, no, in the case of chronic granulomatous disease. And of course, okay, because of that, no, na hindi kayang patayin, no, ng WBC natin yung mga ingested organism. Of course, chronic granulomatous disease is characterized by severe recurrent infections. Okay? Now, let's go to the other functional disorder. We have the Celiac. Okay? Celiac-Higashi syndrome. Okay? So, Celiac-Higashi syndrome is characterized by an abnormal fusion. Okay, abnormal fusion of primary and secondary granules. Okay, and this abnormal fusion of the primary and secondary granules is because of a mutation. No, this is due to a mutation. Okay, mutation in the lysosomal trafficking regulatory gene. Okay, so a mutation in the lysosomal trafficking regulatory gene, and this gene is CHS1 and the LYST gene, no, CHS1 and the LYST gene. So these are the mutated genes, no, that give rise, no, to Celiac-Higashi syndrome. And morphologically, no, we are to expect presence of gigantic granules. Okay, that when stained using peroxidase gives a positive result. No, gigantic granules that are peroxidase positive. So basically, no, both chronic granulomatous disease and Celiac-Higashi syndrome, both of them are functionally abnormal. Okay, but in the case of chronic granulomatous disease, morphologically, the WBCs are normal. Whereas in the case of Celiac-Higashi syndrome, there is a morphological anomaly present, and that is the presence of gigantic granules that are peroxidase positive. Okay? Then we now go to of course, no, when it comes to nuclear abnormalities, no, we are to talk about hypersegmentation, and hypersegmentation is oftentimes a hypersegmentation here oftentimes is a manifestation of nuclear cytoplasmic asynchrony, no? So this is oftentimes associated, no, with megaloblastic anemia. And of course, hyposegmentation is when the the lobules, no, the lobulations of our WBC is less than 2. Okay, less than 2. So we have Pelger-Eway and the pseudo Pelger-Eway anomaly, no. So that is for the hyposegmentation. And of course, for the inherited cytoplasmic anomalies, we have May-Heglin anomaly and the Alder-Riley anomaly, no. So we are to differentiate the two also. Okay, so first we have May-Heglin. So take note that these are cytoplasmic anomalies. So May-Heglin anomaly is characterized, no? This is characterized by large, okay, large crystalline, okay, Dolly-like bodies, no, that are present, no, in Dolly-like inclusions, okay, that are present in the cytoplasm. And of course, May-Heglin anomaly is also one of the disorders that are also characterized of having giant platelets. And because the platelets are larger, no, than normal, they are not counted as platelets, no, especially if the principal use is electrical impedance, no. So because remember that in the case of electrical impedance, we are able to differentiate cells based on their size. So because the platelets here are giant, they are no longer counted as platelets. So we are to expect that the count, no, the platelet count is decreased. Okay, the platelet count is decreased. And of course, no, these platelets are also not functioning well, so bleeding is also a characteristic of May-Heglin anomaly. Okay, so this condition is due to the MY, okay, the MYH9, no, the MYH9 gene mutation. Okay, now the other cytoplasmic anomaly is we have the Alder-Riley anomaly. Okay? So Alder-Riley anomaly naman is characterized by large, okay, azurophilic granules. Okay, large azurophilic granules which contains degraded mucopolysaccharides. Yeah. So this type of anomaly is associated, or yes, no, this is associated with the mucopolysaccharidosis, namely yung tinatawag natin na Hunter, Harler, and Sanfilippo syndrome. Yeah. Okay? So that is Alder-Riley. So take note lang of the azurophilic, the large azurophilic granules for Alder-Riley anomaly. For May-Heglin anomaly, that is large crystalline Dolly-like inclusions. Okay? Now, let us proceed to the monocytic disorders. So for the monocytic disorders, we have two. We have the Gaucher's disease and the Niemann-Pick disease. No? So take note natin dito, no, yung enzyme that is deficient, no, in this condition. So in the case of the Gaucher disease, the deficiency here is glucocerebrosidase. No? So there is glucocerebrosidase deficiency. Okay? So because of that, no, because of this deficiency in glucocerebrosidase, yung glucocerebroside, no, it accumulates in the macrophages, no? So there is accumulation of glucocerebroside in the macrophages. So usually the macrophages of the spleen, the liver, and the bone marrow. These are the locations that are usually affected. And because of that, no, yung macrophages, nagkakaroon siya ng tinatawag na crumpled tissue paper appearance. Okay? So there is crumpled tissue paper appearance of the macrophages. And again, this is because of the deposition or the accumulation of glucocerebroside within these macrophages of the spleen, the liver, and the bone marrow. Okay? On the other hand, no, yung Niemann-Pick disease naman is because of sphingomyelinase deficiency. Okay? Sphingomyelinase deficiency. So, similarly, no, because of the deficiency in this enzyme, yung sphingomyelin kay nag-a-accumulate din sa ating mga macrophages or sa ating mga monocytes. Okay, because remember, no, yung ating macrophage, they arise from monocytes. So, because of the accumulation of the sphingomyelin inside these monocytes and macrophages, it gives it a foamy appearance. Okay? Next, we go to the non-malignant lymphocytosis that is associated with viral infection. So we have three here. We have infectious mononucleosis, cytomegalovirus, and infectious lymphocytosis. So take note natin yung mga causative agents. So infectious mononucleosis is caused by, of course, no, this is caused by Epstein-Barr virus. No, this is caused by EBV, the Epstein-Barr virus. And this virus, it targets the B cells. No, it targets the B cells, and in this type of condition, 'di ba nagkakaroon tayo dito ng mga tinatawag natin na reactive lymphocytes. Okay? So nagkakaroon tayo ng reactive lymphocytes. So usually in the case of infectious mononucleosis, what we have here are reactive, no? Reactive T cells, no? Reactive T lymphocytes. And these T lymphocytes are the ones attacking the B cells. Okay? So, take note natin dito, no, that in the case of IM caused by EBV, your heterophil antibody test is positive. Okay? Heterophil antibody is positive. Next, we have cytomegalovirus. So, this infection will also cause an infectious mononucleosis-like condition. So, this is, lagay natin dito, no, this is similar, no, similar to infectious mononucleosis. Okay? However, no, parati nating tatandaan that cytomegalovirus infection is the most common, transplacentally transmitted infection. So that is commonly transmitted from mother to fetus. So again, no, in the case of cytomegalovirus infection, nagkakaroon ka din dito ng infectious mononucleosis like, no, na manifestations. However, no, ito yung differentiating feature niya. There is no reactive lymphocytes. Okay? No reactive lymphocytes, and it is heterophil antibody test negative. Okay? So that is in the case naman of cytomegalovirus infection. And lastly, we have infectious lymphocytosis. No? So infectious lymphocytosis is commonly caused by adenovirus and Coxsackie-A infection. Okay? Adenovirus, and we have the Coxsackie. Okay, so these are the two causative agents, no, that often results to infectious lymphocytosis. And in this case naman, no, take note natin that there is also absence of reactive lymphocytes. So no reactive lymphocytes. So take note guys no that reactive lymphocytosis no is just associated no with infectious mononucleosis. So again, in this case we have reactive T cells, and these reactive T cells are attacking the B cells. Okay? So, yung magiging highlight no ng discussion natin for this session are the malignant leukocyte disorders. No? So we have 4 groups here. We have acute lymphoproliferative disorder, acute myeloproliferative disorders, we have the chronic leukemias, other lymphoid malignancies, and 5, we have myelodysplastic syndromes. No? So I'm going to discuss no, is selected classifications only. Now, talking about classification, of course, I'm sure no that we already have heard about the FAB, the French, American, British, no, the FAB classification and the WHO classification. So yung FAB classification, that is the old, no, the old classification that is oftentimes discussed na lang or taught in schools, but are not really utilized no in diagnosis. Okay? Because yung FAB classification kasi medyo limited yung basis niya no in classifying these malignancies, no? So ano-ano lang ba yung mga limitations no, or ano-ano lang ba rather yung mga parameters that are being taken into consideration by the FAB classification. So first, actually dalawa lang no, we have cellular morphology. Okay? Cellular morphology, and the other one is cytochemical staining or yung cytochem natin. Okay? And the French, American, British classification, it defines leukemia, no? It defines leukemia as presence, no? Presence of greater than 30%. Okay? Greater than 30% blasts. Both in the bone marrow and the peripheral blood smear. Okay? So that is the definition of the French, American, British classification of leukemia. Greater than 30% blasts. Okay? Now, yung most commonly used, okay? Most commonly used and is considered to be the standard for diagnosis is the WHO classification. So take note, this is the most commonly used and this is the standard, no, the standard for diagnosis. Okay? So medyo complicated lang no yung classification ng WHO because there are a lot of things that are being factored in. So that includes the use of the immunologic probes, yung ating mga CD markers, which is something na kailangan talaga nating aralin in ASCP kasi medyo favorite nila yan. Then, cytogenetics, no? Kino-consider din yung cytogenetics, no? So there are classifications or there are malignancies that are caused by certain translocations, deletions in certain genes, okay? And we have molecular abnormalities, no? Mga mutations. And we have the presentation, no, or yung tinatawag na clinical syndrome, no, the clinical syndrome. Now, based on WHO, leukemia is presence naman of greater than 20% blasts, no? Greater than 20% blasts both in the bone marrow and the peripheral blood smear. Okay? So ito yung bibigyan natin ng focus, no, yung ating WHO classification. Okay, so in the next page no of the manual, meron tayo diyang mga picture no ng mga na-mention natin kanina ng mga certain cytoplasmic nuclear anomalies, no. So for ano na lang to no, this is for your familiarity na lang kasi baka magbigay sila ng pictures, no. One of the students who recently took the exam, no, sabi niya medyo marami-rami daw yung pictures na lumabas sa kanya sa hematology, but most of them are anemia, no. Parang binibigyan siya ng pictures, but anyway, in the case of anemia kasi oftentimes it is accompanied by laboratory findings din or yung CBC results. So sometimes it's easy for us to be able to to narrow down, no, yung mga possible choices natin. Okay? So, yan po. So let us now proceed, no, to acute myeloid leukemia, no? So acute myeloid leukemia. So the WHO have classified this into 4. We have the AML with the current genetic abnormalities, AML with myelodysplasia related changes. We have therapy related myeloid neoplasms, and AML not otherwise specified, no? So dito in-include ko, guys, yung dalawa lang, no, yung AML with recurrent genetic abnormalities and AML not otherwise specified. Kasi when I was reviewing this, no, na-notice ko na medyo nandito yung bulk of the question, no, na whenever they are asking about leukemia. Okay? So ano ba yung mga tatandaan natin, no, na important things, no, about acute myeloid leukemia? So take note, no, remember that this is typically, no, the common type of leukemia that are affecting both adults and infants. Okay? So this is the common, the represents, no, it represents most leukemia, okay, in adults and infants. And remember, no, that if you have leukemia, so typically, no, oftentimes the WBC count is increased. That is because of the increased circulating blasts, 'di ba? Kasi syempre nagkakaroon din tayo dito ng left shift, no? There is increased presence of immature WBC in the circulation, and this contributes, no, to the WBC count. That's why increase yung WBC count typically, no, of acute myeloid leukemia. However, no, it varies depending on the type of acute myeloid leukemia. And yun na nga, no, increase yung ating WBC, no, WBC count, and this is because of the presence, no, of the blasts, okay? Pero again, it is somewhat variable, however, depending on the type of, okay, the type of leukemia. Then also, if you have leukemia, isa din sa mga manifestations nito is anemia. Okay? And the type of anemia is normocytic, okay? Normocytic, okay? Normochromic. Okay? And lastly, of course, no, magiging mababa din yung ating platelet count. Yeah. Okay? So, pakitandaan itong mga genetic abnormalities, no, with these types, no, of AMLs. So first, we have the translocation from chromosome 8 to 22, no? So translocation from chromosome 8 to 22. Okay, so that is the genetic anomaly. Maybe, no, they might be asking of the exact genetic loci, no? So the exact genetic loci, no, meaning yung location sa chromosome, yung part ng chromosome na nag-translocate or lumipat. So this is a translocation from the long arm of chromosome 8 to the long arm of chromosome 21. So specifically in the Q, no, the long arm, the Q22 to Q22.1, okay, of chromosome 22. Okay? Anyway, no, just to give you an idea, ano ba itong Q, mga ganyan. So Q represents the long arm. Pag P, that is the short arm. Then itong numbers na ito, this tells us the specific location kung saan makikita yung gene. Okay? So pag sinabi nating 2, yung unang 2, that refers to the region. So region 2, yung pangalawang 2, that refers to the band. Okay? Tas yung point ganyan, that refers to the sub-band. Okay? So, ibig sabihin, when you say Q22, that means long arm, region 2, band 2. Pag sinabi natin Q22.1, that is long arm, region 2, band 2, sub-band 1. Okay? But anyway, no, most likely ito lang naman yung itatanong nila, no, yung chromosomes involved. Okay? So, this type of AML is affecting the neutrophil lineage. Okay? Take note of the presence of the Auer rods and neutrophilic dysplasia. So this is MPO positive, obviously, because this is myeloid yung kanyang series. Okay? And ito guys yung mga CD markers that are oftentimes positive in this genetic abnormalities, yan yung mga pinakatatandaan talaga. So, if we are to uh, make an association of this AML with caused by translocation of chromosome 8 to 22, okay, this most likely would resemble, okay, this resembles the M2, the M2 morphology. No, yung M2, yung mga M na yan 'di ba yung ating Fab na classification. Okay? Next, we have the inversion in chromosome 16. So pag sinabi nating I16, so that is inversion. No, inversion in chromosome 16 usually affecting the short arm, okay? It's short arm to its long arm. Sorry. Ito na lang. So, ito inversion in chromosome 16. So specifically saan nangyari yung inversion? In the long arm, okay? In the short arm, no? P13.1 to Q long arm 22. Or the other possible cause of this type of AML is translocation from this can also be referred to rather. Kasi pag sinabi nating inversion, basically parang lumipat yung isang part ng chromosome to its other location, but still in the same chromosome. So that's why itong inversion in chromosome 16, short arm 13.1 to long arm 22, pwede mo din siyang parang tawagin na translocation din. Translocation, however, from chromosome 16 to another part of chromosome 16. Okay? So nakukuha ba ito? No? So inversion is basically lumipat, no? Lumipat yung isang part ng chromosome, specifically sa kanyang short arm, no? Lumipat doon. Nagkapalitan sila ng Q22, no? So since parang it's a transfer, no? It could also be referred to as a translocation, but that translocation is happening in the same chromosome, no? Medyo ano lang siya, no? Medyo it doesn't respect talaga yung definition ng term na translocation, kasi pag sinabi nating translocation, this should be between two non-homologous chromosome. Okay, so it's the better term here would be the inversion, no, in chromosome 16. Okay, so if we are to associate this with the Fab classification, this resembles the M4, no, the M4 morphology. Okay, next we have favorite to, no? This is a favorite in the ASCP exam. We have the translocation from chromosome 15 to chromosome 17, specifically from the long arm of chromosome 22 to the long arm of chromosome 17. Okay? So these are the loci, the genetic loci involved, the Q22 and the Q12. Okay? So, bakit favorite itong T1517? Kasi ito yung genetic anomaly associated with APL, no? Ano ba si APL? Ito yung ating M3 in the Fab classification, that is acute promyelocytic leukemia. Okay, acute promyelocytic leukemia, no? So kung meron tayong mga tatandaan dito, guys, yung bundles of our rods, no? The bundles of our rods that are often seen inside your promyelocytes, yan yung tinatawag natin na phagot, okay? Phagot cells. And this is also the type of AML that is most associated with DIC, no? Disseminated intravascular coagulation. Okay? Next, we have the T922. Ay, sorry. T911 rather. The T911. Okay, yung T922 pala para sa CML pa yan. Now, the T911, specifically the loci involved is in the short arm, P21.3 to Q23.3. Okay? So, this type of AML may include, no, may also manifest DIC. Okay, it may include DIC, and also it may be characterized by extra medullary or tissue infiltration. Okay? So, take note that this type of AML is MPO negative and a non-specific esterase positive. Okay? Next, we have the translocation from chromosome 6 to chromosome 9. No? Translocation from chromosome 6 to chromosome 9, specifically in the long arm 23 to the long arm 34.1. Okay? So, this type of AML often resembles M1 or the M4 morphology. Okay? Next, we have the inversion in chromosome 3, no? So inversion in chromosome 3. So again, yung mga inversion, okay, pwede din natin siyang matawag na translocation from one part of the same chromosome to the other. Okay? So this is a multi-lineage dysplasia, especially affecting platelets and the megakaryocytes. Okay? So that's why, no, if you would notice, nandito yung ating CD41 tsaka CD61 because of the effect, no, on the megakaryocytic series. So this type, no, of AML often resembles, okay, M1, M4, or the M7 morphology. Okay? And lastly, we have the translocation from chromosome 1 to chromosome 22, specifically in the P13.3, okay, to Q13.3. Okay? So here, megakaryoblast and megakaryocytes are the ones that are affected. Therefore, nagiging MPO negative siya. Bakit siya MPO negative? Kasi yung MPO will only be positive if it is the granulocytic and the monocytic series that are affected. Okay? So since it affects the megakaryocytes and megakaryoblast, no, consistently nandyan yung ating CD41 and CD61. Okay? So yan po, no, yung ating mga AML with recurrent genetic abnormalities. Okay? So let us proceed, no, to the AML that are not otherwise specified, no, the AML that are not otherwise specified. So first, yung ating tinatawag na M0, no? Yung tinatawag natin na M0. Okay? So sa M0, this is the AML with a minimal differentiation, no? AML, no? So this is AML with minimal differentiation. Yan. Kaya makikita naman natin no evidence of myeloid differentiation or maturation. And thus, it is MPO negative. Okay? Kasi wala pa namang maturation, no? So hindi pa alam whether it's granulocytic or monocytic yung series niya. Okay? So in order for this condition to be diagnosed, no, it requires diagnosis requires immunophenotyping. So when you say immunophenotyping, what we do here is we are looking for these clusters of differentiation on the surface of the cells. So naghahanap tayo ng CD34, CD13, CD33, CD117. So usually these are HLA-DR. So usually these are the markers that can be found in the case of M0. Okay? So next we have the M1, no? The M1. This is the acute myeloid leukemia without, no? Acute myeloid leukemia without maturation. Okay? So, dito, no, the MPO is positive. So, because that is already at least 3% no, of the cell. Kasi yung MPO, guys, no, explain ko lang, no, meron siyang limit eh. In order for you to be considered na positive ka for MPO, dapat yung staining intensity must be at least 3%. Okay? So take note natin in the case of M1 that our rods, okay, our rods or cytoplasmic granules may be present. Okay? And this is actually similar na, no? Similar din siya sa tinatawag natin na M2. So this is also, no, this would also be characterized by presence of our rods and cytoplasmic granules. So M2 naman is the FAB classification for acute myeloid leukemia with maturation. Okay? Acute myeloid leukemia with maturation. Okay? So again, no, dito our rods or cytoplasmic granules may also be present. Okay, so next is the acute myelomonocytic leukemia. Okay, or yung tinatawag natin na M4. Okay, so M4 is acute, okay, So M4 is acute myelomonocytic leukemia. Okay? So both the granulocytic and the monocytic series are affected and thus MPO positive tsaka non-specific esterase positive siya. Okay? So this type of leukemia is medyo maganda yung kanyang prognosis because it often responds to treatment. Next, we have the M5. So take note natin na yung M5, meron tayong M5A tsaka M5B. So this is our acute monoblastic and monocytic leukemia. Yung difference ng dalawa is when you say acute monoblastic, that is M5A. When you say acute monocytic, that is M5B. Okay? So this is acute monoblastic. So lagay ko dito M5A, monocytic, M5B, leukemia. Yeah. Okay? So monoblast from monocytes and monocytes are the ones predominating here, and since this no longer affect, it doesn't affect anymore, yung ating Okay, so again, since yung ating M5 is no longer affecting the granulocytic series kasi mga monocytes na lang ito, and that is the reason why it is now MPO negative. Kasi again, yung ating myeloperoxidase para ito sa mga granulocytes. And it is NSE positive, yung ating non-specific esterase positive na siya. Okay? So anyway, I'll just mention mamaya kung anong mga non-specific esterase na yan. Okay? So now, for M5, take note natin that this will be characterized by presence of tissue infiltrates. Okay. There might be CNS, central nervous system involvement. Okay. and we have hemophagocytosis. Okay? Next, we have M6, no? Yung M6, okay? Or yung tinatawag natin guys na acute erythroid leukemia or erythroleukemia, no? For short. Acute erythroid leukemia. Okay? So, of course, no greater than 80% immature erythroid precursors with at least 30% pro-erythroblast. Myeloblast is less than 20%. Okay? And there will be dysplasia no, in the erythroid cells. So this is MPO positive in the case of myeloblasts because myeloblasts are still belonging in the granulocytic series. So that is MPO positive. Okay, in myeloblasts. And if there's one no staining characteristic na tatandaan natin dito no, or cytochemistry na tatandaan natin dito, that is its PAS positivity, no? PAS positive or periodic acid shift positive siya, no? So I want you to take note also of the markers no for M6. We have CD34 and the CD71. Okay, recall question na yan, no? So this is a rare subgroup no of acute myeloid leukemia, no, a rare subgroup of acute myeloid leukemia, and this has a poor prognosis. Okay, next we have the M7, another favorite no in the ASEP exam, M7, which is acute megakardioblastic leukemia. Okay, acute megakardioblastic leukemia. Okay, so MPO negative siya, NSE positive, but if we are using the acetate as the substrate only, no? So meron kasi tayong dalawang uri ng non-specific esterases. Okay, so we have the alpha naphthyl acetate and alpha naphthyl butyrate, no? So sulat ko dito. Okay, para may guide kayo. So kanina I already have mentioned about MPO. This is myeloperoxidase. Okay. So this is a present, no? This is present, okay, in the granules of the myeloid series. Okay. So next, we have the myeloid series. So that would include the granulocytes, no, the granulocytes and the monocytes. However, no, kanina nakita natin doon sa ating M5 that the MPO is already negative. That is because kanina I mentioned that in order for you to be considered positive for MPO, you must be at least 3% no yung staining no na intensity. Okay? Then we have the NSE, no, yung ating non-specific esterase, okay, non-specific esterase. Okay? So for the non-specific esterase naman, kumbaga mas intense yung staining dito ng ating mga monocytes, no? Mga monocytes naman yung sinistain nito. Okay? So meron tayong dalawang non-specific esterase. We have the alpha, no? The alpha, depende sa substrate na ginagamit. We have the alpha naphthyl acetate. Okay? And the other one is the alpha naphthyl butyrate. Okay? So, in the case of M7, usually kasi yung M7, nagni-negative yan sa cytochem. No? Nagni-negative yung M7 sa cytochem. Except for the NSE, if acetate is being used as the substrate. And of course, kung merong non-specific esterase, meron din tayong specific esterase, which stains naman yung mga granulocytes lang din. Okay? So specific esterase para ito sa mga granulocytes. Okay? So yung specific esterase natin is yung naphthol Okay? Yung naphthol ASD chloroacetate esterase. Okay? So yan po no yung mga cytochem na tatandaan natin. Now, sa M7 again favorite in the ASCP exam, even in my exam this came out. Yung sa akin is the CD61. Yung very simple yung tanong, alin dito yung marker no na nakikita sa M7? Actually yung nakalagay doon is acute megakardioblastic leukemia. So I answered CD61. Then another student no na who also passed the exam, yung sa kanya naman nakapartner na yung mga markers. So look for CD41 and CD61. Kasi sa katunayan guys, itong CD41 and CD61, these are the glycoproteins that are found on the surface of platelets. Yung CD41 to be specific, that is a main component of yung tinatawag natin na GP2B3A, no, the glycoprotein 2B3A, no, na kung saan nagbabind yung fibrin, no, para makapag-aggregate yung platelets. Okay? And CD61 is also it complexes no with CD41 in order for that particular GP2B3A to be formed. Okay? So yan. Now, tatandaan natin no for M7 no that this is characterized no this is characterized by cytopenia. Okay, cytopenia with or without thrombocytopenia. So pwede na maging normal yung platelets in this case. Okay? And we have the type of leukemia that is only affecting no the basophilic precursors. We have acute basophilic leukemia. Okay? So this is a very rare no, a very rare condition no, approximately nasa less than 10% lang siya no of all acute myeloid leukemias. Okay? So the if there is a particular symptom no natatandaan natin in the case of acute basophilic leukemia, the symptom is oftentimes related to an increased level of histamine no. So tinatawag natin 'yon na hyperhistaminemia. Okay? Hyperhistaminemia. No? So this is usually no the culprit no of the symptoms, okay, that are seen, okay, in acute basophilic leukemia. So alam naman natin no yung effect ng histamine no the very reaction no that we are feeling or seeing in a person na nagkakaroon ng anaphylactic or allergic reaction no that is basically no the symptoms no seen in in cases of acute basophilic leukemia. Okay? And lastly, we have acute panmyelosis with myelofibrosis. So acute panmyelosis, okay, with myelofibrosis. Okay, so this is MPO positive, obviously, because it is affecting neutrophils. Okay, so there will be a marked peripheral blood pancytopenia. Yung mga characteristic nito, marked peripheral blood, PB, no? Peripheral blood pancytopenia. So mababa lahat ng cells, okay? There is bone marrow, no? Bone marrow panmyelosis with fibrosis. Kaya with myelofibrosis yung tawag sa kanya. Okay? So yan po no yung ating mga acute myeloid leukemia that are not otherwise specified. No? So usually ito yung medyo may relation with the FAB classification. No? So again, emphasize ko, yung pinaka-importante dito is yung mga CD markers. Oftentimes ito talaga yung tinatanong nila. Okay? So now let us proceed to another group no of malignant, no? Malignant leukocyte disorder, we have myelodysplastic syndromes. Okay? So ano ba itong mga myelodysplastic syndrome? So these are myeloid neoplasms characterized by ineffective hematopoiesis which eventually displays cytopenia, dyspoiesis in at least one of the major myeloid lineages and increased risk of developing into acute myeloid leukemia. So this type of condition is usually seen in older adults. Okay? So this is usually seen yan. Usually seen in older adults. However, no, if nakikita siya sa mga younger adult, oftentimes that is because of a secondary manifestation. Kumbaga, if myelodysplastic syndromes are seen in younger adults, usually this is secondary to chemotherapy, secondary to exposure to radiation, exposure to benzene, or it could be a bone marrow failure, an inherited bone marrow failure such as Fanconi anemia. Okay? So again, myelodysplastic syndromes are usually seen in older adults. But if they are seen in younger adults, it is usually secondary to chemotherapy, secondary to radiation exposure, secondary to benzene exposure, or it could be secondary to a bone marrow, to an inherited bone marrow failure such as Fanconi anemia. Okay? Now, if there's a laboratory finding, no, natatandaan natin dito, no, of course there will be a hypercellular bone marrow. Lab findings. So dito. Okay? So we have hypercellular bone marrow. Okay? And unlike acute myeloid leukemia, the blasts here are less than 20%, no? Less than 20% blasts. Okay? And you are to expect many, okay, dysplastic changes. No, many dysplastic changes affecting each of the cell lineage, both in the peripheral blood smear and in the bone marrow, no? So many dysplastic changes both in PBS, peripheral blood smear, and the bone marrow, no? So pag sinabi natin na dysplastic changes, again, it could affect, no, dysplastic changes affecting any lineage. So what are these? No, so let's say for example, if it affects, no, the erythrocytes, no, so tawag natin doon poiesis. Yan. Okay? So ano-ano ba yung mga example, no, ng dysplastic changes? Of course, no, magkakaroon ka ng anisocytosis, poikilocytosis. Okay? You are to expect basophilic stippling and other inclusions. Okay? Other inclusions. You are going to expect irregular cytoplasmic staining of your RBCs. Okay? Presence of ring sideroblasts, which is used, no, as one of the basis for the classification, no, the ring sideroblasts. Okay? Now, also magkakaroon din ng dysplastic effects, no, with our granulocytes. So tawag naman natin doon dysgranulopoiesis. Okay? So that would include hypogranulation. Okay? Or pwedeng abnormal granulation. Okay? This is also associated with pseudo, no, the pseudo-Pelger-Eway anomaly, which is characterized by hyposegmentation, di ba? Hyposegmentation ng nucleus. Okay? And pwede ding magkaroon ng hypersegmentation. Okay. Of course, no, there could also be presence of immature WBC, syempre because this is a myelodysplastic syndrome, okay? And possibility, no, meron ding mga hour rods. Okay? So, yan. And of course, no, if it could affect the RBC, if it could affect the WBC, it could also affect our platelets. So magkakaroon ka din ng megakaryocytopoiesis. Kasi nga guys, from the name itself, myelodysplastic syndrome. So there is a dysplasia of the myeloid lineage. Ano ba yung nag-a-arise sa myeloid lineage? Yung RBC natin, yung WBC natin, tsaka yung ating mga platelets. So in the case of this megakaryocytopoiesis naman, pwede kang magkaroon ng maliliit na megakaryocytes, no? So micro megakaryocytes. Okay? Pwede kang magkaroon ng hypogranulation, konti yung granules, which is alam naman natin na necessary ito talaga for platelets, or pwede kang magkaroon ng large abnormal granules. Okay? There could be presence of giant platelets. Okay? Pwede ding magkaroon ng mga functional abnormalities yung platelets. Yan. So, my point here is in the case of myelodysplastic syndrome, it affects all lineages. So magkakaroon guys ng dysplasia, magkakaroon ng dysplastic changes in affecting all three lineages under the myeloid lineage, okay? And possibly pwede siyang mag-progress into acute myeloid leukemia. Okay? So meron tayo ditong 7 major categories. Okay? So, sorry, ito. So we have 7 major categories. So itong 6, ito yung mga WHO classification, 6 sila. Then this is the MDS unclassified. So 7 classification all in all. Okay? So and usually the basis of this classification, take note natin, the basis of this classification is based on the degree of dysplasia and cytopenia. Okay? Pakidagdag na lang para alam natin ano yung basis ng classification. So the WHO scheme of classification of myelodysplastic syndrome, first is based on degree of cytopenia, okay, and dysplasia. And pag sinabi nating cytopenia, okay, pag sinabi nating cytopenia, ito yung mga kumbaga ito yung mga definitions natin for cytopenia. So first we have hemoglobin, okay? Hemoglobin of less than 10 grams per DL. Okay? Next is platelet count of less than 100 times 10 to the third per microliter. We have the absolute. Okay? Absolute neutrophil count of less than 1,800 cells per microliter. Then we have the peripheral blood monocytes. Peripheral blood to of less than 1,000 per microliter, no? So convert na lang natin, no, kasi baka ma-confuse kayo sa value. This is less than 100 grams per liter, no? This could be 100 times 10 to the 9 per liter, no? So this is less than 1.8 times 10 to the 9 per liter, and this is and this is less than 1.0. Okay, 1.0 times 10 to the 9 per liter. Okay? Another basis of the WHO classification is the percentage of blast in the peripheral blood and bone marrow. Okay, the percentage of blasts in the peripheral blood and bone marrow. And percentage, no, yung na-mention ko kanina, we have the percentage of ringed sideroblasts in the bone marrow. Yeah. Okay, so yan po yung mga basis, no, ng classifications natin for the myelodysplastic syndrome. So again, we have 7, no? We have 7 groups here. So among this group, I want you to take note lang of the one with the 5q deletion. So this one has the favorable prognosis. Okay? So you might be seeing terms, no, pancytopenia or bicytopenia, because again, sabi nga natin, no, in the case of myelodysplastic syndrome, it could affect at least one of the major myeloid lineages, no? So pwedeng it could affect one, it could affect all, no, it could affect two. So pag sinabi nating pancytopenia, so basically it affects all three. Okay? Bicytopenia if it only affects two. Okay? So yan po, no? So anyway, ito naman yung kanilang mga characteristics na, no, of the number of the blasts and the ring sideroblasts, again, as part of the basis of the classification of myelodysplastic syndromes. Okay? And we now go to our last, okay, group of malignancies. We have myeloproliferative neoplasms. So the myeloproliferative neoplasms are a group of closely related malignant disorders that result from autonomous clonal proliferation of hematopoietic stem cells. So although this is characterized, no, by abnormal proliferation of all myeloid lineages, usually it will only affect one cell line, no, or there is one cell line that is prominently involved or prominently affected. Okay, so myeloproliferative neoplasms are usually affecting middle-aged, okay, middle-aged or older adults. Okay? So here, no, for better studying, no, grinupo ko na lang yung apat na yan, tsaka yung mga characteristic nila when it comes to their peripheral blood morphologic changes and yung kanilang molecular tests. Okay? So first, no, we have our chronic myelogenous leukemia. Okay? Chronic myelogenous leukemia. So ano ba yung mga dapat natin natandaan when it comes to CML, no? So earlier, I think I mentioned, no, about CML being as something, no, that must be differentiated from leukemioid reaction. Kasi itong si CML, guys, no, CML is characterized by it exhibits, no, a complete spectrum of granulocytic cells in the PBS. Anong ibig ko sabihin doon? Lahat-lahat ng stages ng granulocytic series nakikita sa peripheral blood smear in the case of chronic myelogenous leukemia. And having said that, ibig sabihin meron tayong mga mature WBC na nakikita, no, sa peripheral blood smear. Okay? So there is a marked elevation, no? There is a marked elevation in the WBC count. Usually that is greater than 50, no? Times 10 to the 9 per liter. Hemoglobin is normal or might be decreased. Platelets are variable. Okay? In the peripheral blood, white blood cells will be immature, and it might exhibit eosinophilia and basophilia. Okay, so you are to expect, nor you are to see immature granulocytes, because again, in the case of CML, all stages are found in the PBS. Okay, RBCs are normocytic and normochromic, and platelets are occasionally enlarged or giant. Now, for the molecular test, of course, no, Philadelphia chromosome is present. No, Philadelphia chromosome is present in the case of CML, whereas the JAK2 mutation is absent, and marrow fibrosis is progressively increasing. Okay? Progressively increasing yung marrow fibrosis. Now, we mentioned about the Philadelphia chromosome. Ano ba ito, no? Ano ba itong si Philadelphia chromosome na ito? I think I mentioned earlier, no, that CML is actually caused by a translocation from chromosome 9 to 22. No? So baka tanungin, ano yung genetic anomaly or cytogenetic anomaly associated with CML? Okay? That is a translocation from chromosome 9 to chromosome 22. Now, technically kasi dito sa ating chromosome 9, no, sa ating chromosome 9, dito nakikita yung ABL gene. Okay? Sa chromosome 9 dito nakikita yung ABL gene, whereas sa chromosome 22 dito nakikita yung BCR gene. So what happened is naputol, no? Specifically this is in the Q, the long arm. Okay? So naputol yung portion ng long arm ng chromosome 9, and included in that fragment, no, that was a cut, no, from the long arm of chromosome 9 is the ABL gene. Tapos yung nangyari, naputol din yung part, no, ng chromosome 22, yung long arm ng chromosome 22, pero naiwan sa chromosome 22 yung BCR gene. Okay? So basically yung nangyari, let's say this is the long arms of the two chromosome. Okay? This is your ABL gene, and let's say this is your BCR gene. Okay? Yung nangyari, guys, naputol to. Yan. So ito, this was cut in chromosome 9. Tapos, in chromosome 22 naman, ito yung naalis. Yan. In chromosome 22. So, in the formation of the Philadelphia chromosome is actually a change chromosome 22. Wherein, no, this is actually a change chromosome 22, wherein nagkaroon ng fusion yung BCR tsaka yung ABL gene. Yan. Naging ganyan. So this is now your Philadelphia, no? This is now your Philadelphia, okay, chromosome. A change chromosome 22. So this is what we call the BCR-ABL gene fusion. Okay? Which is characteristic of chronic myelogenous leukemia. Okay? So, yan. Okay, so itong si CML also, meron din siyang mga stages, no? May mga stages ito. So meron tayong tinatawag na dormant, no? May tinatawag tayo na dormant stage. Okay, dormant, we have accelerated. Okay, accelerated, and we have the blast, no? The blast crisis. Okay? So usually pag dormant yung stage, yung blast is less than 10%. Pag accelerated, no, nasa 10 to 19% na daw. Then pag blast crisis, greater than 20% na yung blast, no, for the stages of chronic myelogenous leukemia. Okay? So yan po. So take note, no? Yan yung mga findings natin for CML. Now let's go to polycythemia vera. Polycythemia vera is the WBC's if there's something natatandaan natin dito sa polycythemia vera, that is pancytosis. Ibig sabihin, lahat-lahat ng cells natin sa PBS tumataas. Not just WBC, but also the platelets and the red blood cell. Okay, so the WBCs here are moderately elevated. No? Moderately elevated lang siya. Nasa, mataas siya, but not exceeding 30. No? Not exceeding 30 times 10 to the 9 per liter. Okay, hemoglobin is markedly elevated. Why? Because PV is characterized by erythrocytosis. No, this is characterized by erythrocytosis. And platelets might be normal or elevated. Okay, so WBC, there are no immature granulocytes. Occasionally, eosinophils increase and nagkakaroon din ng basophilia. Okay? RBCs are normocytic and normochromic, and platelets might be, the PBS might exhibit megakaryocytic fragments. Okay? Philadelphia chromosome here is absent because Philadelphia chromosome, guys, is only associated with chronic myelogenous leukemia. JAK2 mutation is present in approximately 95 to 100% of the cases, and the bone marrow fibrosis is also progressively increasing. Okay. Next, we have PM. No, PM means okay, so PM here means primary myelofibrosis. No, primary myelofibrosis. So here the WBC is variable. Okay, hemoglobin is decreased. The platelets are variable. Of course, since there is myelofibrosis, immature granulocytes are present in the peripheral blood smear. Occasionally, there will be increase in eosinophils and basophilia. The red blood cells will exhibit the cryocytes. No, this is something to take note. The presence of teardrop cells in the case of myelofibrosis, and megakaryocytic fragments and large platelets might be found also in the PBS. Okay, Philadelphia chromosome is absent again, and the JAK2 mutation is present in 95 to 100% of the cases. And marrow fibrosis is not progressively increasing, but is already markedly elevated. Okay, markedly elevated na yung marrow fibrosis. And lastly, no, we have essential thrombocytosis. No, ET is essential thrombocytosis. WBCs are normal or elevated. Okay, hindi siya mag-exceed ng 30 times 10 to the 9 per liter. Okay, hemoglobin is variable and platelets are markedly elevated. Actually, nasa criteria yan, no, ng WHO na for it to be considered as essential thrombocytosis, dapat at least greater than 450 times 10 to the 9 per liter yung platelet count. Okay, so occasionally there might be immature granulocytes in the peripheral blood smear. No, mild eosinophilia and basophilia may be possible. The red blood cells are normocytic and normochromic, and the platelets are exhibiting a marked variation in the size and shape. Okay, and Philadelphia chromosome is absent. Okay, JAK2 mutation is seen in approximately 55% of the cases, and marrow fibrosis is progressively increasing. So far yan po, no, yung ating mga myeloproliferative neoplasms. Okay? So I think that ends, no, our lecture on the different leukocytic disorders. If there are disorders that I failed to mention here, na I have included din naman, no, sa them naman, no, sa ating final coaching, no, because there are isolated, no, na mga, kumbaga may mga isolated questions. I only included those, no, na high yield, no, in this particular session. So that would be all for this session. Maraming salamat.